Hello, my name is Marina Esfaya, and today I will be presenting a clinical vignette case about primary hyperaldosteronism presenting with hemorrhagic stroke. As a brief introduction, primary hyperaldosteronism is the leading cause of secondary hypertension. Although it is an independent risk factor for acute stroke, it seems to be underdiagnosed as a cause of hypertensive emergencies. Here we discuss a case of a patient who presented with hypertensive emergency and stroke-like symptoms and eventually found to have hyperaldosteronism. The patient is a 46-year-old male with a past medical history of uncontrolled hypertension and hypokalemia, who was admitted for acute onset left-sided numbness and weakness associated with slurred speech. On admission, blood pressure was 292 over 156 millimeters of mercury. Physical exam revealed flaccid paralysis of the left upper and lower extremities, decreased sensation to light touch and pinprick in the left side of the body. Initial potassium was 2.2 millimolars per liter. CT scan of the brain revealed intracranial hematoma in the right basal ganglia, measuring about 1 centimeter. The patient was first started on strict blood pressure control with IV medications and transitioned to oral antihypertensives and potassium supplementation. Given resistant hypokalemia, plasma renin activity and aldosterone levels were ordered, which revealed to be 0.771 nanograms per milliliters per hour and 24.4 nanograms per deciliter, with a ratio of 31.26, being greater than 20. The patient was started on Dactone, and CT abdomen and pelvis with contrast revealed a 1.3 centimeter nodule of the left adrenal gland. The patient's blood pressure and electrolyte abnormalities improved. Further evaluation with adrenal vein sampling to localize the functional adrenal tumor and possible surgery deferred until his neurological deficit improved. This case report emphasizes the consequences of primary hyperaldosteronism, given that the aldosterone excess has detrimental cardiovascular and cerebrovascular effects that are in part independent of high blood pressure. Early detection of a disease that was previously believed to be rare has an essential impact in clinical outcomes and survival, especially in the younger populations. Studies have shown that the overall risk of stroke was almost 3 times higher than that of patients with essential hypertension. Despite this elevated risk, the most significant problem is underdiagnosis, especially as the screening test is often not even performed. Screening guidelines for primary hyperaldosteronism consist of serum aldosterone-renin ratio, only done when there's a suspicion for a secondary hypertension cause. The diagnosis of primary hyperaldosteronism should not only rest on endocrinologists, but also on primary care providers, who are initially the point of contact when hypertension is first detected. In conclusion, primary hyperaldosteronism is an identified risk factor for cerebrovascular accident. However, its diagnosis can be challenging if the cerebrovascular accident is the initial feature. This case sheds light on considering primary hyperaldosteronism among the differential diagnoses when facing younger patients presenting with cerebrovascular accident in the setting of persistent hypertension and hypokalemia. Once diagnosed and adequately treated, it decreases the risk of cerebrovascular accident and avoids further complications.